Good afternoon. We're going to go ahead and get started. There will be some people coming in, so just ignore them as they come in. Don't worry about that. This is our fifth community of interest, and we've had one each semester for the last four, hence this being the fifth one. Today we're going to be talking to and with some researchers on campus, scholars who are really interested in the area of substance abuse, and the hope is that lots of you also have a similar interest here. As you remember, the communities of interest, and particularly the Ignite talks, are an opportunity for you to see what other people on campus are doing, so there may be some possibilities for some collaborations and other kinds of things. Really, this is an initiative by the Vice President, the Office of the Vice President for Research, Innovation, and Economic Development. And as such, Dr. Kolaroo, Vice President Kolaroo, should be the one who kicks it off. So Ramesh, if you'll say a few words for us. I know you're reluctant to speak, but we'll give it the shot.
Because unlike Magdi, I'm very bashful. But thanks, Jack, and thank you and the staff of the research office, you, Dominique, and Pearson, for your ongoing efforts to convene the conversation. This, as Jack said, is the fifth in the series of these communities of interest, which have all served and come together and have been convened with different areas of focus, because what we wanted to do is to bring researchers and practitioners from across multiple disciplines, and that may have not much in common other than the topic that they're working on, but from their own perspectives. But when you bring people together that look at a problem from their discipline's perspective and allow an afternoon where those disciplines and those lenses through which they look at the problem come together, and when those lenses come together, sometimes things look clearer, and maybe there's an opportunity to have solutions and breakthroughs or collaborations, if nothing else. And as such, this is one of those conversations, and it's a conversation about a tough topic. It's a topic about opioids and substance abuse, which, as you may know, last year we had 62,000 deaths in the United States because of opioid addiction. That year, 62,000 births happened in the state of Louisiana. So each year, we are losing as many people across the country as the birth population of the state of Louisiana. And when you pause to think about it, and when you pause to understand the human condition and the human tragedy that undergirds those data, that begins to tell you that this is a problem that requires a research university like ours to at least have a conversation. And that's what this is. Today is a conversation. I have no idea what will come out of it, but this conversation hopefully leads to collaboration between people that are convened here, that are speaking and that are listening in. And those collaborations can maybe, just maybe lead to problem solving. And that's what we are hoping will happen today. That's what we are hoping to also have happen on April 13th and 14th, when we are hosting, in partnership with the Department of Health and Human Services, the department at the federal level, USDA at the federal level, Senator Cassidy, the Secretary of the Louisiana Department of Health, Congressman Higgins, the Chief Technology Officer of the United States for Health and Human Services, and many other folks from Blue Cross Blue Shield, Microsoft. All of these folks are coming together on our campus, April 13th and 14th. Please mark your calendars for an opioid summit. It is a Friday and Saturday, where Friday morning we begin with a series of conversations from policymakers, public servants, practitioners, healthcare workers, who all will have a conversation about the magnitude of the problem, what is being done to solve the problem. And then at noon that day, we'll have a bunch of geeks like myself, hackers and coders, that will get introduced to a lot of data that has never seen light of the day. And they're going to hack away for the next 24 hours, eating lots of pizza and drinking lots of caffeine, I'm sure. But they're going to be producing solutions over a 24-hour period, and will hopefully have contributed to solving the problem. That's our goal, that's our hope, and that's what we are trying to do. So with that said, I want to get out of your way and wish you a great conversation. Thank you.
We're fortunate also to have, as we've had in the past, Dr. Pearson Cross is our moderator today. So Pearson, I'll give it to you.
Thank you, and thank you, Dr. Culler. It's exciting news about the opioid conference. This is, as you've heard, our 5th community of interest. They've all been somewhat different, but somewhat the same. But they've been the same in the sense that they have all been interesting and provocative and have created new ideas and new collaborations. And we certainly think and hope that this one will be the same. Today, we're going to have 8 presenters speak for 6 minutes each, talking about their research, their interests, their ideas for research within this broad area of substance abuse and other related areas. The slides that our speakers are going to be using are prepared visually rather than textually in most cases. They will be talking while these slides are being presented. We have a strict time formula, so this will prevent them from tarrying too long at any one spot and will move us along towards our destination. We divided the speakers themselves into 2 sessions. Both sessions will host 4 speakers today, and then we're following that with a 35-minute conversation, a social discussion time when you can get together and you can talk to those presenters. Those presenters are going to be at tables in the lobby. You can exchange ideas. You can tell them what you thought about their presentation. You can talk about ideas. You can group. You can actually, or you can just eat the food, I guess. During this, so you'll be interacting. After that 35-minute period, we're going to have a second session with the final 4 presenters, followed by yet another opportunity to talk and eat some more food. It's our hope that you will be able to that this session will help you develop your research interests and broaden your knowledge in the area of substance abuse and what's going on in this particularly important area today. If I could remind you right now to make sure that your cell phones are turned off so that we don't have any interruptions. We are recording today's session, which is going to be up on AOC for later use, and we certainly thank them for being here. Today's topic is one with a real aura of immediacy. The federal government, state health authorities, and numerous clinicians, researchers, and commentators have discussed the problems of substance abuse involving opioids, as well as other substances used and ingested in America and the world. There's a real opportunity to work in this area to try to solve some of these issues. So let's get started with our first session with our first speaker. The first speaker is Dr. Paula Zena from the Picard Center and from the College of Nursing and Allied Health Professions, who will be presenting Underage Drinking, What's the Problem?
Ready to go? Good afternoon, and indeed I'm here today to talk about underage drinking and to think about what is the problem. What I'm presenting today reflects in part some of the work that's being done at the Picard Center, so I want to make sure that I acknowledge my collaborators here. When you talk to other adults, you often hear people make the kind of comments that you see on this slide. It's as if many adults think that it's acceptable, that it's normal, and that maybe even it's desirable that young people drink. And so, does those attitudes really align with what we know about substance use in young children? Today I'm going to talk about how adolescence is a period of vulnerability, highlight some of the aspects of current underage consumption, and look at some of the consequences as well as some of the solutions. We know that adolescents are vulnerable. It's a time of great, they're not finished products, and they're still in that transition from childhood to adulthood. And so biological as well as social influences make a difference and impact their vulnerability to alcohol use. We know that the brain is changing, and for many adults, that adolescent period, the brain seems like a black box. But in fact, a lot of reorganization is going on so that the brain can have more efficient information processing and make that more complex decisions as they get older. The maturation occurs from front to back and isn't complete until the mid-20s. We know that the areas of the brain that are responsible for emotions and interaction with and incentives mature much faster than the parts of the brain, the prefrontal cortex, that makes for decision making. Peers also have a big influence on what they do. In Louisiana, high school students, about 20% of them indicate that they have friends who think that drinking at their age is okay or maybe even cool. Our family influences are very important as well. Family history brings a biological risk for those families who have a strong history of alcoholism. We know from the ACE surveys, the average childhood experiences, that young adults who experience adversity during childhood are much more likely to have substance abuse and alcohol use later on. And we know that the community also has important influences. Again, these are from what our adolescents tell us, and many of adolescents in the communities are seeing their communities as either accepting or they make access fairly easy for them to get a hold of alcohol. In fact, Louisiana's minimum drinking age, as you probably know, is 21, although they're trying to get it to 19. We have several exceptions that make it possible for people under the age of 21 to legally get alcohol. We are in the minority in some of those states with those kinds of laws. So next, I'm going to talk to you about actual consumption. We've talked some about risks. And if you look at this slide, this comes from the Caring Communities Youth Survey, which is managed by the P-Card Center. And what you'll see here is that both in 30-day alcohol use reports and binge drinking, these are high school students that are giving us these reports. In Louisiana, Louisiana youth in general drink much more frequently than their U.S. peers. If you look specifically at 8th graders, the 8th graders are almost twice as likely as their U.S. peers to report any kind of drinking, and more than twice as likely to report binge drinking 8th grade. So that's really important to pay attention to. Obviously, the amount of drinking goes up as they get a little bit older. There's also very interesting data that suggests that there are differences ethnically as well, with white youth reporting much more drinking than other ethnic groups. What else am I going to tell you? I think this is a very telling slide and important in terms of thinking about what our youth doing. If you look at college students, of course, that's where many of you all are concerned. We see that the majority of students acknowledge drinking some. And for those who are reporting as heavy drinkers or binge drinkers, about a third of college students admit to that. And as drinking increases, the chances of them using marijuana, illicit drugs, reporting getting in trouble because of misconduct or personal problems also goes up. It's not surprising that, given the brain development that they have and their development, that they're more likely to encounter these kind of what I would call short-term consequences, which are very significant. But there's also some long-term consequences. And interestingly, despite what a lot of people say, a brand new study shows that adolescents who are given alcohol by their parents are more likely to have alcohol use problems later on. We also see those who initiate very early much more likely to have alcohol use disorders in adolescence and in adulthood. And we even see adolescents, a fair number, I think 5% doesn't seem like a lot, but it is a lot, who actually can be diagnosed by psychiatric criteria as alcohol use disorder. So what helps? There's a number of areas that people are trying to infuse prevention and intervention. A lot of these have variable amounts of evidence behind them in terms of their effectiveness. And nonetheless, given the vulnerability of adolescents to alcohol and substance abuse, we need to continue to carry on in terms of our research. Thank you very much.
Thank you, Dr. Zena. Our next speaker is Dr. Amy Brown from the Department of Psychology and the College of Liberal Arts. This talk is entitled, Does Alcohol Intoxication Impact the Intentions and Behaviors of Bystanders to Sexual Violence?
Good afternoon. So efforts to prevent sexual assault on college campuses are increasingly focusing on the role that bystanders can play in preventing sexual violence. In this talk, I'm going to ask the question about how alcohol impacts bystanders in these situations. So evidence of the role, or an illustration of the role that bystanders can play in preventing sexual violence, comes from real life examples of people stepping up to either assist victims or apprehend perpetrators, as we saw in California in 2007 or at Stanford University in 2015. We know that alcohol is a major risk factor for sexual assault. This implies that when bystanders have the opportunity to intervene, then they may also be under the influence of alcohol, as they exist within the same alcohol-fueled context that sexual assault happens in. One of the more prominent models of bystander intervention suggests that bystanders have to pass through a number of steps before they'll offer assistance. They first have to notice the incident in the first place, they have to interpret it as an emergency, and then they have to assume responsibility for helping. It is likely that being under the influence of alcohol could impact or could reduce the likelihood of helping at each of these stages. Other models of bystander intervention suggest that people are also sensitive to the cost associated with helping and will be less likely to help to the extent that costs are high. However, alcohol may impair attention to costs and thus, according to alcohol myopia theory, people may be less likely to intervene if the need for intervention is more subtle, but if the need for intervention is very, very clear and obvious, then actually alcohol might increase people's helping behavior. There are some studies that do suggest that alcohol might reduce the salience of a victim's need for, or the danger that a victim's in. Alcohol has been shown to be associated with more acceptance of interpersonal violence, less sensitivity to cue signaling need for intervention, and less empathy. Two recent studies have found that heavier drinkers do report less willingness to intervene. However, not all of the time. There are a number of contextual factors, and this relationship is not straightforward. So my students and I have conducted 4 studies looking at the relationship between drinking and bystander intervention. We've looked at both typical drinking behavior as well as in the moment drinking behavior. We've asked people about their willingness to intervene in the future as well as their experiences with intervening in past situations. Study number 1 found that heavier drinkers reported lower intentions to intervene in the future, and they reported higher levels of intoxication whenever they had the opportunity to intervene. They also reported more missed opportunities for intervention, but they did not report fewer experiences intervening in the past. Study 2 had similar results. Study 3 had people read hypothetical vignettes. The first one of those vignettes illustrated a sexual assault in a party context that was meant to convey a more obvious risk, and then another illustrated a sort of risky situation in a bar that was meant to convey more subtle risks. Different versions of these scenarios varied whether the victim was a stranger or a friend. We looked in this study perceptions of danger and concern, confidence in their ability to intervene, and willingness to intervene. I know there's a lot of numbers, but just pay attention to the few, that there are only a few associations between alcohol and perceptions or intentions. Heavier drinkers reported less perceptions of danger and concern in one scenario, but they reported greater confidence in their ability to intervene in another scenario. In a different scenario, interactions involving gender suggested that people that drink, or that men that drink more frequently actually are more confident and more willing to intervene. This study also found that people on average who drank more, people who drank more heavily or often in social situations were more willing to intervene. But none of these studies illustrated how actual drinking in the moment impacts decisions. So in study 4, we actually went out to people where people were drinking, and we gave them one of the scenarios from study 3, and we had them respond to the scenario. We measured their intoxication with a breathalyzer. The average BAC was 0.057. Faster than I meant to. In this study, we looked at perceptions of danger and concern, but we also looked at perceptions of cost associated with intervening and willingness to intervene. We actually found that intoxication was related to none of the variables that we measured in either scenario. So to summarize the results of these studies, we found that heavier drinkers reported lower intervention intentions in 2 of the studies, but not in the other 2 studies. In one study, we actually found that more frequent drinkers were more willing to intervene. We found that heavier drinkers do not report fewer behaviors, but they do report more missed opportunities, and that alcohol intoxication has no impact on bystander perceptions or intentions in a hypothetical scenario. So where does this leave us? Actually, we really can't definitively answer the question that we started with. There's too many, too many more additional questions about how and why drinking might impact bystanders. We do know that drinking college students are not a lost cause. We should increase our efforts to train students to be able to effectively intervene. And we need to find out whether these programmings are effective at all levels of drinking behavior. So one potential solution is to give people salient reminders of when they participate in a training program, something like a wristband that reminds them of the skills that they learned so that they can remember to employ those skills even when they're under the influence of alcohol. Whew, that was fast. Thank you guys so much for paying attention.
Thank you, Dr. Brown. The third speaker is Dr. Chan Chin from the Informatics Research Institute. He's going to speak on Unveiling Opioids Epidemic, an informatics approach.
Hello, I'm Jen Chen from CVDI and Informatics Research Institute. Today I'm presenting an informatics approach to unveil the opioid epidemic we're facing. Opioids can treat moderate to severe pain, can also be useful for treating coughing and diarrhea. And opioids also can make people feel high and very relaxed. And there's so many opioids data out there, such as opioid-related deaths, hospitalization, patient treatment, prescribing pattern, and even a behavior survey. But the real challenges are how we can leverage those data, how to ask the right questions, and then how to find the answer to those questions. And informatics can help. There are so many types of analysis, and different kind of analysis will bring in the user different level of value and also with different level of difficulties. For example, descriptive analytics can tell you what happened. And exploratory analytics is helpful to understand why did it happen. And predictive analytics is helpful to understand what will happen. And then the more advanced predictive analytics will answer the question like, what are the best course of actions? And let's start with some simple statistics. We know that more people die from opioids than from gun violence. So many people being treated in emergency room because of opioid overdose. And Louisiana is one of the top 8 states struggling opioids crisis. And the economic cost of such epidemic are significant to this country. And here are some national average data about opioid-related hospital use. From 2008 to 2016, the rate of inpatient stay almost doubled. In the same period, the emergency department visit almost tripled. And the next slide, the CDC analysis will tell us from 2000 to 2016, in the overall opioid-related death rate increased 4.5 times. And among them, the synthetic opioids-related deaths increased the most. If we look at it geographically, the death rate by average, the West Virginia is a hotspot in 2013 because there's so many minors there. But in 2015, new hotspot emerged in New England area. The reasons are unclear yet. And let's look at the opioid deaths number in Louisiana. Those parishes, Jefferson, Santani, Orleans, East Baton Rouge, top the list. No surprise, those are major urban areas in the state. But if we look at per capita number, there are some surprise. The top city of Medicare claims related to opioids per capita, the top city is Covington in St. Tammany Parish in 2013. If we look at 2015, Covington still topped the list, but you see that per capita cost is triple within 2 years. The rapid expansion of elder care facility in that city probably can explain why. Let's look at the top opioid drug being described. In 2013, in Louisiana, the top 3 are hydrocodone, tramadol, and oxycodone. And all of them are painkiller with high risk of addiction. In 2015, the top 3 doesn't check the order, but But the third one, oxycodone, tripled in both in terms of cost and the number of prescriptions. If we look at the top opioid prescribers in Louisiana, internal medicine, family practice, physical medicine and rehabilitation, and interventional pain management are the top 4 group in 2013. If in 2015, then physical medicine and rehabilitation and the interventional pain management at the top 2 in terms of cost, but also 3rd and 4th in terms of prescription numbers. If we look at where other prescribers are, you can see that most of them clustered in a few cities. And we define opioid prescriber that those physicians prescribe at least 10 opioids a year. If we, interesting about pair of special group and city, the top list in 2013 are physical medicine and rehabilitation in Baton Rouge, internal medicine in New Orleans, internal medicine in Alexandria in 2013. But in 2015, there's a new champion. The interventional pain management in Baton Rouge, physical medicine and rehabilitation in Baton Rouge. Lastly, I want to talk about one predictive analytics example. We want to predict how a physician likely to prescribe opioids based on the specialty group as well as the non-opioid prescribing train. Our machine learning model can predict with 82% accuracy. More interestingly, when we plot the relative importance of different features of the model, we found that the top features are not the special group as we expected. Instead, there are different drugs, especially the top 2. Both have more than 50% importance. The top one, hydroxyzine, is the method to treat anxiety, vomiting, and allergies. The second one, oxycodone, is about so those methods. Thank you.
Thank you, Dr. Chen. Our 4th speaker and final speaker for this first session is Ms. Jada Hector from the Department of Criminal Justice and the College of Liberal Arts. Her presentation is entitled Opioids, What Are We Missing?
Yeah, there's a bit of an overlap, but it's different. It'll be fine. So hi, I'm Jada. I'm a clinician, and I've spent the last 12 years of my career working with clients and patients who suffer from substance abuse. So my perspective is coming from, we have all this data and information about opioids, but what are the missing links that are out there, and how can we work together in communities to overcome that and better serve our clients and patients? And so I grabbed a few little headlines. I mean, we know this is an epidemic. We're talking about it as if it's a public health crisis at this point, and this was stuff that I grabbed just a couple days ago. It's in the topics, it's in the news, but again, how are we all getting together in conversation like this one to better overcome, better work together to plan out things, like the one we talked about in April that's happening. So even in Louisiana, my questions come from things like, how well does our public know what's happening? We are all here having a conversation about it right now, but does the lay person who's at home at this moment know what kind of risk they're at? Where's the awareness? Where's that conversation coming from? I'm skipping ahead already. Yeah, awareness, planning, communication, and treatment. So I want to talk a little bit about each of these things and how they work together, and again, getting that information out there, making sure that our public is aware of these issues. We can talk about numbers, we can talk about deaths, but again, does my grandmother know that the risk of the drugs in her cabinet are going to be for her? Does the risk of my nephew being at her home and possibly being exposed, those types of things? You saw this slide in Dr. Chen's presentation, but I want to point out that here the CDC is saying that 1 in 4 people receiving prescription opioids in long-term primary care struggles with addiction. So 1 in 4, that's an exorbitant amount of people. That's a huge number, and we're saying struggles with addiction. So then that addiction then can come and lead to other things, as you see here, and I'll extremely point out that 40 times over there. So we're saying that opioid painkillers, if you're someone who's using those, are 40 times more likely to be addicted to heroin. So that brings us to a different conversation. It's oftentimes that the heroin epidemic or the heroin issue is something that's it's not in my area, it's not my problem, but we're seeing this direct 40 times link. I also provided you with the Louisiana Department of Health data for the last few years as a local issue. You'll see Lafayette's on there, it's kind of a lower number. but it's still in that ballpark. And the next slide is a great side-by-side that I'll talk about because I myself am from Lafayette, but I live in Orleans Parish right now. And it's funny that I've had a conversation with, again, like Dr. Chin said, St. Tammany being somewhat of an issue. And I recently had a conversation with a government employee there, and we talked about the risk. And to the perception of the public, the risk is in Orleans. The risk is Orleans where that's the problem. But in reality, you'll see that St. Tammany is double what Orleans is. So it's kind of, again, going back to that awareness. Does the public know what their risk is? We talk about federal grants, we talk about lawmakers. Again, I showed you guys some slides that were headlines, but where's the action? And that's what is really driving me crazy right now. What are we doing differently? We've talked about in the past, there's been the war on drugs and different concepts like that, but how is this different? How are we treating it differently? And then again, the big thing, let's keep in mind, these are prescriptions being given by a doctor. So the perception of the public is, my doctor gave me a prescription, I should take it. As a doctor, that's a medical professional giving me advice. So that has a different element when it comes to treating, because if I'm being told to take this thing, and then now it's a problem, or I'm at risk, or I don't know my risk, and I'm being 1 in 4 maybe. And here you'll see again, the number of prescriptions written per person. So there's, in 2013, 123 prescriptions were written for 100 people. That in number in and of itself is impactful. And again, you'll see that in the last, 4 years, it's been over 100. And here we are, and it was a breakdown of men to women. There's been some studies and evidence to show the difference there. But I kind of just wanted to point out those direct numbers and seeing that huge difference when we're talking about, as Dr. Chin mentioned again, we're in the top 8 states. So what are we doing again to make sure that that's out there, that information has become part of our conversation? As far as treatment goes, we talk a lot about harm reduction, and in the opioid treatment, there's often MAT, medication-assisted treatment, which is the Suboxones and the methadones. But is it working? Can we sustain that cost? Are we using it in the way the manner that it's been prescribed? Oftentimes, it's something to titrate a person off from these drugs, but are they actually at that schedule? Is that happening? Then we talk about Narcan. Narcan will save someone's life, and in the harm reduction concept, if someone is in an overdose right now, they will not die if they're using this, and a layperson can use it. But is that a Band-Aid? Is that what we're using? We're talking about that from more of a reactive standpoint, but what about the proactive standpoint? I know that the Department of Health has been issuing Narcan out to the public. Anyone can go and get it at a pharmacy, and it can be easily used. But again, are we having that conversation so we're not getting to that point? And even the topic of medical marijuana on both ends has come to play, as in a pain treatment as opposed to opiates, but also there's been some information coming out about using medical marijuana in a treatment process to then not use opiates. So again, my standpoint coming from a clinician side is, what are we doing to make this change? How are we coming together to have these conversations to better educate the public and people who are at risk about what's going on? Just so that we can kind of connect those dots. And I have one more impactful slide. So CDC information yesterday, on average, 115 people will die today in America from an opioid overdose. So that in and of itself says a lot. Thanks.
All right, thank you, Ms. Hector. Now, please join us and the 4 speakers for food, drink discussion and some posters out in the lobby.